Dr. Christopher Sweeney is well known to many of us, and we're really delighted to have him this evening. Dr. Sweeney is a professor and medical oncologist currently at the Dana-Farber Cancer Institute, and really an international expert in genitourinary malignancies. He's been on multiple seminal studies that he's led for advanced prostate cancer, over 250 publications in the prostate cancer space. And I'm really overwhelmed that he agreed to join us to give us a talk about treatment selection in metastatic hormone-sensitive disease, which has continued to evolve. So thanks so much for being here tonight, Dr. Sweeney, and I'll turn it over to you.
Thanks a lot, Ashley. It's a great honor to have been invited and share some thoughts on treatment selection. Metastatic hormone-sensitive prostate cancer is the title, and could also ask the question, is there a role for docetaxel anymore? Some people have raised that conversation, and I would say yes, maybe sometimes, and I'm going to try and qualify that statement. So here are my conflicts of interest with consulting and research funding, and the conflict at the bottom there is the PI of the CHAARTED and study co-chair of ENZAMET, and I think we should nominate these as conflicts of interest because it may impact how we as investigators view and present the data. So what are the problems to fix in metastatic hormone-sensitive prostate cancer is the first question I've just asked. There is the issue of undertreatment. Many patients are just receiving ADT alone when we know adding something to ADT improves overall survival. And other patients, even though we do give them intense therapy, even triplet therapy, ADT, DOSI, ABI, for example, have poor responses and die of their disease way too quickly. Then the other issue is matching the wrong treatment with a given patient. So we need to work out what is the most active treatment for a patient with a given cancer. And then the other issue is overtreatment. Can we stop treatments in a patient who have a durable response? And these are all issues I think we should keep at front of mind as we design our next round of therapies, trials. So the fix number one I want to think through is, can we prevent undertreatment? It's well documented that very few patients are getting docetaxel or abiraterone, apalutamide, enzalutamide added to ADT. But what I would first of all say, we need accurate data, as we do not document what the population is that was studied. Were they chemo fit for docetaxel? Were they suitable for abiraterone, apalutamide, enzalutamide? Were some patients getting radiation to the prostate for de novo low volume in lieu of docetaxel or the hormones? It in itself is a life-prolonging therapy. And were a number of the patients with oligometastatic disease getting SBRT, and that's a strategy deployed by many. Whether it's the right strategy is another question, but to say that new therapies are not being added to ADT, we need to actually get a better picture of what is actually happening. And the other thing is, I think we the research community, need to define the best treatment plan for a given patient. And I think we can use clinical factors to define the therapy with the best therapeutic index for a given patient, and aim to deploy the most activity with the least toxicity. So here is what I do in my current practice in taking the following features into account when trying to develop personalized treatment selection. We've got patient factors, what is their preference, what is their lifespan, what are their comorbidities and frailty, and do they have access? What are the finances? What are the approvals needed? And what is it safe to give docetaxel in a COVID surge when you may have alternatives? On the other side, as the cancer factors, what is the prognosis of a patient given the distribution of the disease? Did they present with de novo / synchronous disease, or do they have a delayed relapse presentation with metachronous metastases? And the extent of metastases, is it a couple of spots or is it many spots? I just list here, biology will play a part in the future, but we've got a lot of work before we have gene expression profiling, exome profiling, epigenetic factors, germline, molecular imaging that will guide our therapy. Right now, we have no data to deploy any of these strategies, but I do think it will be the future state. So first of all, let's just set something straight. There are a number of different prognostic groups. They basically all say the same thing in different ways. So first of all, we're just focusing on SWOG, MD Anderson, CHAARTED, and Latitude. 4 different cooperative groups. Latitude, I should say, is a pharmaceutical sponsored study. SWOG studies were done in the 80s and 90s. They had patients who presented with synchronous metastasis, the MD Anderson data I'm referencing, synchronous metastasis, CHAARTED, synchronous metachronous, and then latitude synchronous only. But then you look at the poor risk stratification. Any lesion beyond the pelvic body and vertebral bones or visceral metastasis was SWOG. And then MD Anderson said 3 or more, or the presence of visceral metastasis. With CHAARTED, I combined both of those, SWOG and MD Anderson, trying to limit misclassification of a patient who may have 3 areas of bony metastasis in their spine and maybe a couple of areas of DJD. And is it DJD? Is it cancer? And trying to maximize the chance that minimize misclassification is why I tried to amalgamate both definitions. And then latitude was 2 of 3 Gleason score greater than 8, greater than 3 bone lesions and visceral metastases. But the key thing is they are different ways of saying the same thing, with median survivals of 27, 37, 34, and 33 months. What's notably, and then the good risk patients who did not have the poor risk features, 51, 94, 60, and 60. So pretty much they're saying the same thing, but there is some variability in the good risk patients, and we'll come into why that may be the case. And we should also say the SWOG study is based on data from the 1980s and 1990s, and that's why their numbers are probably the least in a cooperative group, because they didn't have all the therapies for castration-resistant disease. Now, STAMPEDE is absent from here because they have not been prospectively stratifying patients by any risk system. They've been looking at M0 and M1 as their stratification factors and analyzing them as one group. And that's a style that they've, and a design approach that they've taken. However, they did go back and prospectively develop an analysis plan after they had accrued the study and broke the patients down into those who had 3 or less bony metastases with or without regional lymph nodes. And one can see the patients who had the best outcome for radiation to the prostate were those who had a good prognosis. So it's all telling you the same thing, I think. There's patients with a lower burden of disease, in this case, may benefit more from radiation to the prostate, where most of the active cancer may be, and the hormonal therapy does well on the more indolent, lower burden disease. So what about combining both risk factors? So a patient who has metachronous and low volume disease has a median survival of about 8 years. And this is the patient who had a prostatectomy, say, in 2002. Their PSA slowly rises and finally gets to a level of about 10, and a scan is done and 2 bony metastases is seen 8 years later. And this patient's median survival is about 8 years. Many of them may be treated with just SBRT alone, like the STOMP and the ORIOL trials that many may be aware about. And then metachronous and high volume and synchronous and low volume both have a median survival of about 4.5 years. So we can talk about an intermediate risk group. And then synchronous and high volume consistently a median survival of about 3 years with hormonal therapy alone. We then looked at this in the Dana-Farber Cancer Institute data set on the right. So the left data is from CHAARTED and GTUG, clinical trial cooperative groups, one in the United States, one in France. But we can see that we replicated this very consistently with a hospital registry data set at Dana-Farber, with the blue being metachronous and low volume, red being synchronous and high volume, and median survivals of about 8 and 3 years, as we can see there, and the intermediate group there is listed. Notably, most of the patients with low volume disease were actually metachronous low volume, not the de novo low volume or the synchronous low volume. And very few patients are actually have high volume disease after localized curative prostatectomy or radiation given with curative intent, and very few relapse with high volume disease. And I just want to point out this group, this study here, of continuous versus intermittent androgen deprivation therapy for patients with a relatively rapidly rising PSA after their prostatectomy or radiation. And this group had a median survival of about 8 years. Let's also recognize that many of them were probably PSMA PET positive. But also when we see in this study, 60% of the 524 deaths were not prostate cancer related. And this median survival is also very similar to the median survival of the metachronous low volume with disease seen on a CAT scan or bone scan. So I think this is a very unique group that needs to be considered differently to other patients with metastatic hormone-sensitive prostate cancer. So a lot of people will say, well, PSMA PET's going to revolutionize everything. And yes, it will, but I don't know how it's going to. And it's clear, it is a better imaging. In high-risk disease where conventional scans are negative, we may see more disease on a PSMA PET. Same with a patient with PSA rise after prostatectomy, nothing on a conventional scan, may see something on a PSMA PET. Some patients who are oligometastatic on conventional scan may actually have more disease on PSMA PET, and patients with high volume may actually even be more high volume on a PSMA PET. How we use PSMA PET to improve patient outcomes is not known, and we have to be cautious about overusing it and maybe mistreating patients with good intent, but not maybe with the best of potential outcomes for a patient. The scenario that I'm most worried about is a patient who has an isolated 5mm retroperitoneal lymph node outside of this radiation or surgical field, and people say, okay, that's metastatic disease, and they're going to treat them with hormone therapy alone as opposed to curative therapy with hormones for systemic micrometastatic disease and radiation. Another conversation for another day. But here are the extreme faces of metastatic hormone-sensitive prostate cancer. One is the 55-year-old with no comorbidities and high-volume de novo metastatic versus the 82-year-old with congestive heart failure and coronary artery disease and 2 bony metastases 10 years after a prostatectomy. I think we can easily conclude that these patients need different treatment paradigms. And I think we're getting more data. And I'm just putting this slide up here just to show the extensive amount of data that there is for us to look at to start to make some personalized decisions. So there's the chemotherapy studies with Docetaxel, CHAARTED, GTOG, STAMPEDE, androgen synthesis inhibitors, STAMPEDE Latitude with Abiraterone and STAMPEDE ARM-G, ENZAMET and ARCHES with enzalutamide, apalutamide, external beam to the prostate with HORAD and STAMPEDE, external beam radiation. And excuse me for the typo here, apalutamide, that should be abiraterone plus docetaxel plus or minus radiation with piece 1. Enzalutamide with ENZAMET, we'll have some patients who've got docetaxel that we're going to report longer term data on hopefully soon, and the ARASENT study. So there's thousands of patients of data with different patient prognostic variables that we can start to look at and try and see which groups benefit from which therapy. And here is my current guidance for docetaxel versus hormonal combinations in metastatic hormone-sensitive prostate cancer. So I'm giving you my answer, and then I'm going to show you my working to the question. Based on all the data, I think the question comes down to triplet versus amide versus abiraterone alone depends on fitness for chemotherapy, fitness for apalutamide, enzalutamide, no seizures, no frailty, fitness for abiraterone, blood sugar, hypertension, liver function, evidence of a consistent overall survival benefit for a given setting with use of a given agent, and preferably an agent with no decrement in quality of life on therapy. And if chemo fit and high volume, I actually am thinking about docetaxel with abiraterone with an asterisk, thinking would love to see that we can confirm that with ENZAMET and and ARASENT, but to be determined, but indeed very encouraging. And if chemo fit and low volume and not amenable to surgery or radiation, I actually prefer the hormonal therapy approach, but because there's consistent evidence with that approach, with adding abiraterone or the amide, but less evidence for docetaxel. But if you don't give docetaxel for hormone sensitive, don't forget about it for castration-resistant disease. So why do I say this? So here is the high-level summary of the hazard ratio overall survival of docetaxel added to testosterone suppression, TS, with or without docetaxel. And you've got it's like a bit of a maybe evidence of benefit when you look at all of the M1 together, when you look at all of the study, GTOG 15, CHAARTED, and STAMPEDE docetaxel. And what you can see, the hazard ratios of 0.88, 0.72, and 0.81. Pretty okay. Then if you look at high volume de novo and metastatic, you see a stronger signal, 0.78, 0.63, and 0.81 across all three studies. And then you see a bit of more of a mixed signal with low volume de novo of about 1 point, close to 1 for GTOG 15. We need to get that exact data presented and 0.86 and 0.76 for Stampede docetaxel. And then you look at the low volume metachronous, you see no evidence of benefit. Granted, the numbers are small, confidence intervals are fairly wide, but there's 2 studies showing these patients have no evidence of a benefit. Stampede did not have had less than 5% of their patients in this category. So I think there's evidence of a dose effect. Those who have the more rapidly progressive poor prognosis, high volume, do have a clear benefit, a modest benefit for low volume de novo metastatic, but I put red around low volume metachronous because there's no evidence of a survival benefit. And what isn't published and what I can show is that when you do a test for interaction, there is a difference between low volume and low volume metachronous and high volume de novo metachronous, but that's a work in progress. And you've just got this dose effect where you've got this intermediate with low volume and de novo. So I think it's reasonable to give it to low volume and de novo, but I do think you've got better treatment options with the hormones and radiation to the prostate, but a definite red around the low volume metachronous. Now, if you just look at the Stampede docetaxel alone, you'd say, okay, clearly low volume, not otherwise specified, it does just as well. But I think it's a lot more granular than that. And we have to look at all the data and make a patient-centered decision, not one based on one study with one retrospective review. And just also to point out, they're missing 25% of the scan data. And so their data is good. This was said to be going to be much larger than all of the other data sets. It's not that much larger. 124 had docetaxel because of the 2-to-1 randomization. And also, it's retrospective and they're missing 25% of the data. So I say no benefit for low volume metachronous, modest benefit for low volume de novo, and then a benefit in high volume. And here are the Kaplan-Meier curves showing all of what I just showed. De novo low volume on the left, metachronous low volume in the middle for CHAARTED and GTUG combined, and then it's the unique finding, which is a bit of an outlier. There was a non-proportional hazard ratio there, as one can see. The p-value was greater than 1, and the confidence interval was greater than 1. So if you look at it in isolation, you go, well, maybe it's not that strong, but when you do a test for interaction, it didn't look different to the high volume. So it just depends on what you look at and how you present the data. We actually did the test for interaction for high volume and low volume within CHAARTED, and you can see there was clearly a difference in effect. Now, again, I'm going to say this is driven by the low volume patients, not the low volume metachronous, not the de novo low volume. We also did this with the GTUG and CHAARTED together. And when you can see here again, there was a test for heterogeneity showed that the high volume patients benefit, but the low volume patients did not when you did a pooled analysis of the aggregate data for both of them. But again, I'm pretty confident that's driven by the low volume metachronous rather than the de novo low volume. The reason why I think, why do we need to be cautious about docetaxel? Well, you've got to choose patients that are chemo fit, and a clinical trial is the best case scenario for that. And even then, we still had grade 3 and 4 toxicities, life-threatening neutropenic fever, and we actually did have a death, a pulmonary-related death, but it is not for everyone, is my message. And we need a bigger return on investment to justify using docetaxel on its own in patients with metastatic hormone-sensitive prostate cancer. Here also, we look at the quality of life by low volume. You can see no evidence of a quality of life benefit in the low volume patients, and there was a slight decline. In the high volume, they had poorer baseline quality of life scores, as you would expect, but also by number, wide confidence intervals. And then they actually did have a better quality of life at 12 months, despite a modest decline still within noise at baseline with therapy, because you're controlling the cancer with the hormones and docetaxel, and you're decreasing the cancer symptoms, so the quality of life was a wash at the beginning, but better because of better long-term control at 12 months. So there's much more granularity to chemotherapy does or doesn't improve quality of life in patients with metastatic hormone sensitive when you look at it by the extent of their disease and the clinical benefits seen. Now, I think we should be making a lot more noise about radiation to the prostate for patients with de novo low volume disease. We have 2 studies which have a consistent signal for patients with 4 or less bony metastases. This is an aggregate meta-analysis that was done by the Stopgap group, where basically there was a 27% decreased rate of death and a 7% improvement in 3-year overall survival with simple radiation to the prostate. And I would, if I had to choose between docetaxel and radiation to the prostate for a patient with low volume disease, I would choose radiation to the prostate any day ending in Y, as they say. So a close look at the fine print behind the mixed results. GTUG-15 was conducted in an era with minimal access to agents other than docetaxel for prostate cancer. The Kaplan-Meier curves for de novo low volume are overlapping. Retrospective scan data on all the patients. CHAARTED was prospective and a stratification by volume disclosure of the PI of the CHAARTED study. And STAMPEDE is missing 24% of the patients in the retrospective analysis and does not include patients with metachronous low volume. So the bottom line is probably some patients with low volume de novo metastatic benefit, but not large enough to see clear treatment effects across all trials. That is of a magnitude to, I think, justify docetaxel when you've got other less toxic agents. But there are even patients with high volume who probably do not benefit and need it because they respond so well to the hormones, and we need biomarkers to sort this out. It is unknown if there's a treatment effect with docetaxel in low volume after radiating the prostate in de novo low volume, and that also holds for the hormones, but I would choose the hormones over docetaxel in that setting for the reasons I will show in a second. So here is the alternative data with adding the hormones to testosterone suppression, be it Abiraterone with Latitude and STAMPEDE, granted nearly all of these patients with de novo metastatic, ENZAMET, which is a little bit complicated because it had concurrent docetaxel, and the data is here from the interim analysis, and Titan apalutamide and Archer's enzalutamide. And what one can see is that a clear all M1 consistent overall survival with hazard ratios of 0.67 to 0.66, 0.65. And we see the same effect with abiraterone and the amides, and the treatment effect is preserved in patients with high volume. And what I should say, that hazard ratio of 0.53 of the patients who did not get docetaxel with high volume disease in the ENZAMET study. So that's just the hormones alone, enzalutamide added to testosterone suppression, not those who had docetaxel as the triplet therapy, something we'll talk about in a second. And then a very consistent signal with hazard ratios between 0.39 and 0.72 for low volume disease, be it de novo and metachronous. And we actually have been able to look at metachronous low volume in, so metachronous disease in ENZAMET and Titan, and as you can see, there's a survival benefit there. When we do an aggregate meta-analysis, it's a 60% decreased rate of death in patients with metachronous M1. And this is the data specifically from CHAARTED, from ENZAMET, and I'm just focusing on the low volume, metachronous low volume and de novo low volume. You can see there's a consistent effect for both of those groups. In high volume metachronous, we can see, and de novo, that this includes docetaxel or patients who did not get docetaxel. But what I want to really point out is that this is the first time we've actually seen a survival benefit for the metachronous low volume, where we're increasing the survival with enzalutamide from 83% to 92% at 3 years. This is the first time I'm going to reiterate that we see a survival benefit for this subgroup. Don't see it with docetaxel, and I suspect we would see it with abiraterone and enzalutamide and apalutamide, and hopefully darolutamide when that study gets reported. But so my message is, any day I would easily choose a hormone approach for a patient with metachronous low volume and would not even consider docetaxel for this patient population. There is another question for radiation to the oligometastatic lesion. That's another conversation for the radiation oncologist in the room who will probably say, but what about SBRT? Here we actually, here's the aggregate meta-analysis that I just wanted to show, and the need for data. I think we need to do a study of testosterone suppression plus the hormones plus or minus SBRT in these patients Others would argue, well, why don't we just give SBRT and decrease the hormonal therapy for longer and defer it? It's a conversation that has to be had. But my approach is to double down on the hormones and give the SBRT, then stop the hormones and see if we never see the cancer again. Now, what about patients with liver metastases or visceral disease? So first of all, we did see a clear survival benefit with docetaxel in patients with high volume disease with visceral metastases. That's here, this forest plot here. Latitude liver only, the hazard ratio was 0.482, so not as good as docetaxel would appear. Then visceral is a mixed bag. ENZAMET, I've got it grayed out because these patients got docetaxel and many of them got docetaxel and enzalutamide. And so we need longer follow-up there. But with Titan it was 0.76 and with ARTES it was 1.16. So I think right now, if you had to choose and the patient was chemofit, I think chemotherapy would be a part of the treatment paradigm, especially for patients with liver metastases. But we also know lung metastases get lumped in with visceral and they have a good prognosis. And my preference is the hormonal therapy approach for patients with the more hormone-sensitive lung-only metastasis. So the next question is, do we give Abiraterone, docetaxel, or all three? So this is the only data set I think we'll ever get comparing Abiraterone to docetaxel. And what one can see is that, sure, when you give a hormonal therapy, you control the PSA for longer. Failure-free survival is longer with the hormones, but cancer-specific and overall survival pretty much a wash, whether you get docetaxel or Abiraterone. So these were patients accrued at the same time in the Stampede study to the Abiraterone arm or the docetaxel arm. So it's not a direct comparison, head-to-head comparison. 60% of the patients were M1. Some of them actually would have got radiation to the prostate per the N0 cohort that got radiation. So bottom line is that's what we've got. Now, what about the triplet therapy? So the top two rows here are patients who got testosterone suppression plus or minus apalutamide. 11% got docetaxel prior and to apalutamide. 18% got docetaxel prior to enzalutamide in ARCHES. Smallish numbers, clear improvement in radiographic progression-free survival reported with Titan, but not a overall survival benefit. Now, piece one is concurrent docetaxel, complicated design, many arms, but 60% of the patients got concurrent docetaxel. So they got testosterone suppression, ADT, docetaxel plus or minus abiraterone. 710 patients, all de novo, 64% high volume, clear radiographic progression-free survival, and a clear survival benefit for the de novo high volume and less clear for the de novo low volume. But look at that. That looks very similar to adding docetaxel to testosterone suppression alone, doesn't it? And then with ENZAMET, which was an interim analysis at only 33 months, 71% of the patients were high volume, a clear improvement in radiographic progression-free survival. But with 33 months, the overall survival was too immature in this group that was doing better with the docetaxel as baseline. So 5-year overall survival, 50% for de novo high volume, 65% for de novo low volume with the triplet therapy is where our new benchmark is. So here's the survival curve. So a clear separation of the curve for adding abiraterone to ADT and docetaxel, whereas we do not see that clear separation in the de novo low volume subgroup. Numbers are small, follow-up is relatively short for this group, but at this stage, the prevailing winds would suggest that if you're going to give triplet therapy, it would be to patients with de novo high volume disease. Here is the data with ENZAMET. So testosterone suppression plus docetaxel plus or minus enzalutamide clear our clinical progression-free survival, which equates to radiographic progression-free survival, but not an overall survival benefit, but few patients beyond 3 years. And actually, let's just go back. And what you can see is that there was a bit of a separation of the curve here, but it gets more pronounced later. So hopefully we will see that separation beyond 3 years with our next follow-up data, which we are 15 events shy of triggering the next analysis. So drum roll, please. and waiting with bated breath. Now, without docetaxel, there was a clear radiographic progression-free and overall survival benefit with adding enzalutamide to the patients who were not deemed candidates for docetaxel. So what is my treatment plan by risk group? So a patient who has good risk with testosterone suppression, metachronous low volume, 3 or less bony metastases, ABI, ENZA, or APA, and I do add on SBRT, but we need a clinical trial to fix the unknown. Patients with metachronous high volume disease, it's rare, they have a poor prognosis, they have a benefit from docetaxel, we saw in CHAARTED, although the numbers are small. So TS, Abiraterone, and docetaxel, but if not a dosing candidate, the hormones, but we need trials. Intermediate, 4.5-year survival, synchronous low volume disease, radiate the prostate or ABI or ENZA. And if I was going to do a triplet, it'd be radiate the prostate and add the hormones and consider SBRT. But if the disease is too extensive and multiple nodal lesions, I'd think about docetaxel, like someone with high volume nodes with abiraterone. But again, this is way off what the data would tell us to do. It's speculation. But the synchronous high volume, I'm leaning to testosterone suppression, ABI plus docetaxel, or if not chemofit, ABI, ENZA, or APA. But we need trials and we need the follow-up with ENZAMET and the data from ARASENS. But this is what we're dealing with. We need to involve the patient in the treatment choice. If chemofit, the question is not, do I give docetaxel? It's when. Some patients may like to get the chemotherapy out of the way. I don't know if a number of you are fretting. You've had the patient that were fit for chemotherapy when they were hormone sensitive. 8 years later, they're not so fit. And do we have to put them through docetaxel to be able to get them to lutetium PSMA? And now I'm wondering, would it have been helpful to get the chemotherapy out of the way 4 or 5 years ago? Avoid chemotherapy in a COVID pandemic, I think, is something we need to consider. Patients do prefer orals to IVs if they can afford it, but we need to avoid our personal biases. Now, let's turn over to emerging biological data and think through that. So here is a GAP6 November project, and they basically did the exome profiling and focused on the genes here, P53, Wnt, cell cycling, P10, PI3 kinase, biochemical recurrence, PSA rising after prostatectomy radiation, oligometastatic, so metachronous low volume on conventional scan, polymetastatic post after local therapy, so metachronous high volume, and de novo both high and low volume. What one can see is there's an increasing mutation frequency with increasing volume and synchronous metastases, as one would expect. P53, Wnt cell cycling genes, and one can see is that the biochemical recurrence and the oligometastatic have a similar mutational burden and have the same about 8-year survival with testosterone suppression alone. Now, we really need to ramp up the numbers, and we do plan to do this work with CHAARTED, ENZAMET, and STAMPEDE samples as part of ascap.movember.com. Now, let's try and look at this in terms of treatment effect and see if we see a signal. Metachronous, relapsing, low volume, and high volume is listed here. No benefit for docetaxel. No benefit for the oligometastatic, for biochemical oligometastatic, but a benefit with the hormones, AR inhibition. Yes, benefit for high volume with docetaxel, metachronous, and the hormones. De novo, synchronous and high volume. Low volume, so high volume, clear benefit, I think. Low volume, inconsistent for de novo metastatic, but no benefit for low volume metachronous, as we said, but inconsistent and less of a benefit in the de novo low volume. Radiation for prostate, only relevant for low volume de novo, and then the hormones work for low and high volume metachronous and synchronous high and low volume. Now, trying to do some biomarker work, this is very preliminary and I think very near and dear to Dr. Schaefer's heart. So we looked at the Decipher AFI array. So this is not the Decipher score, but we were able to have the company Decipher, now known as Veracyte, do the AFI array using all the RNA transcripts, and we were able to devise the basal gene expression profile and the luminal B gene expression profile from the prostate primaries. This is the same basal and luminal B for breast cancer. And what one could see is that there was no benefit with adding docetaxel to those with the basal gene expression profile, but it looks like a very pronounced effect with a statistically significant in the luminal B, even with the small numbers of the patients we were able to get from the CHAARTED study. We are trying to see if we can confirm that in the STAMPEDE study, and that work is almost underway. Something else we saw is looking at a germline SNP in this HSD3B1 that's been heralded by and pioneered by Nima Sharifi. And what one can see is that this limits extragonadal DHT synthesis from DATS, and it's the blue curve here, and they tended to have a better survival than patients who have the gold have a potentially high dihydrotestosterone synthesis and have a poorer survival. So are these patients the low volume patients who benefit from adding enzalutamide and APA? I don't know. We will answer that question in the ENZAMET study in collaboration with Nima and his team. Interestingly enough, where the patients who did benefit from docetaxel, where there's probably more of an AR negative disease, there was no effect with the HSD3B1. So this is just a look at me, how wonderful hopefully we are or will be, where we have thousands of patients to actually do the biomarker data using gene expression, tumor prostate cancer primary profiling, gene expression, exome immunohistochemistry, germline DNA, serum plasma, and to do proper training and validation biomarker work. Now, I put this here to ask the question, can we stop therapy in some patients? So we've got this, here's an anecdote, 66-year-old patient in 2010 with lip hip pain and sciatica. And MRI showed this very large isolated lesion in his pelvic bone. Gleason 8, 2 years of hormones and radiation to the bone met and the prostate. Stopped the therapy in 2013 because it was undetectable. PSA less than 0.05, his testosterone rose, it stayed down there. Testosterone stayed down, but his testosterone started to wane. And as of October this year, his PSA is still undetectable. And the only issue is that his testosterone is waning as he's now in his late 70s and hasn't had hormonal therapy now for 8.5 years, coming up on 9. So is there a role for potentially curing some patients with SBRT? To be determined. But the only way to find that out is actually if we stop the testosterone suppression. Another project is with Movember. We're trying to identify 200 men treated with oligometastatic disease with ADT and radiation to the mets and the prostate if it was present, and see is there a rate of 20% with long-term off of ADT with PSA staying less than 0.2 with testosterone recovery. I think my earpods have just died. Ashley, can you shout out?
We can hear you just fine, Dr. Sweeney.
Fantastic. There was a nervous moment there. So moving on. So if so, can this data support treatment discontinuation studies? A provocative question, I know, but I want to throw it out there. So here's a study design that I would ask that we think about, as I said, ADT plus Abiraterone or apalutamide or enzalutamide versus SBRT versus the triplet, and discontinue the therapy at 2 years and see how many people have not recovered, not had a rise in their PSA and had a normal testosterone at 5 years. Next fix, I think we need to work on, can we overcome this early resistance? So we've thrown 3 lines of therapy, 3 classes of drugs to this: testosterone suppression, potent AR inhibition, docetaxel, and we're still having patients die in the first 2 years at about a 25% rate. So what's the biology driving this relapse? And are there potential targets we can go after? And this is a study that in castration-resistant disease, where we used exome profiling for PIK3CA, AKT, and PTEN, and there was an rPFS benefit of 0.65 when an AKT inhibitor was added to abiraterone. Now, will that potentially translate to improving the outcomes of men with hormone-sensitive disease? It's a question. There is a study ongoing with capivasertib in this setting, and potentially abemaciclib is another agent that's being evaluated in castration-resistant disease, as well as the PARP inhibitors with niraparib. Now, the other thing is, can we take these findings to the adjuvant setting and further improve the impressive survival benefits, both MFS on the left and OS on the right, when abiraterone was added to testosterone and radiation for patients with high-risk localized disease, and can targeted therapies improve upon this even more? And the other thing I do really think we need to focus on is, can we work on a way to prevent men presenting with de novo metastatic disease and deploy potentially curative therapy and prevent metastases and death ever happening by germline exomes, SNP data, lifestyle modification, healthcare access. And that's another something for us to focus on as a global effort. And with that, I would like to stop my slides. And stop screen sharing, I think, is probably the best thing.
That was phenomenal. We'll open the floor up. Anyone wants to ask any questions of Dr. Sweeney?
So this is Maha.
Hey, Maha.
Hi, Chris. Very nice. And I have to say, we share similar ideas, which is very, is that good or bad? I don't know, but that's great.
It's great.
One of the issues, I think, and this is the project that we're working on, that we assembled the group of people, and I would love to hear your comments, is how are we going to translate everything here now that we have the PSMA PET?
The honest answer is, I think it's probably come down to, I'm not going to change any of my management plans yet. The question, I think, is, do we need a bone scan? So I'm going to look at a patient and try and characterize their cancer burden by looking at the PSMA PET avidity and see how many of those lesions correspond to frankly positive cancer that we see on the corresponding CAT scans. So do they have clear sclerotic lesions that correlate with that? Yes or no? Do they have lymph nodes greater than 2 centimeters? Yes or no? And then I would still classify them as low and high volume disease based on the extent of the disease. But will I, for a patient with de novo low volume on conventional CT scans, but more disease on a PSMA PET, I will treat them with radiation and a hormonal therapy approach with Abi, Enza, or APA. I would not use the dose of the more extensive disease on PSMA PET to justify giving them docetaxel. I would not use the PSMA PET to justify giving them triplet therapy at this stage.
And I fully agree with that. That's great.
Chris, that was awesome, and I really liked your. I always like your stoplight charts: green, yellow, red. So,
thanks.
I saw you channeling your inner stoplights there. One of the columns I would suggest maybe adding for your next talk, or maybe you can expand on it here, is cost.
Oh,
so
sure.
You did not include cost, and we're talking triplet. It's going to be quadruplet. How do you think about that? Because that seems like a huge, another confusing but important area to consider for our patients today.
Absolutely, and I think that's Ed Schaefer's voice. Am I right?
That's me. It's Ted. Sorry, Chris.
Yes,
yeah,
sorry, Ted. Sorry,
yeah.
Thanks. I just wanted to clarify. Yeah, Ted, 100%. That's why I say we need to bring the patients into the conversation of what is their insurance and how much does it cost. The other cost that we need to think about is, I now have a number of patients, I suspect you all do, who are 5 years out on ADT and enzalutamide or apalutamide or abiraterone. PSA is less than 0.2. They're starting to get frail and older, and I don't think the hormones are helping that. Sarcopenia is settling in. So I think not only is it, can we help with cost by actually revisiting a treatment break and see if we can bring that thing in to improve their metabolic and their physical health after 2 years, not the 6-month swab intermittent type style, but something where they're in a deep remission and can we have a treatment break? I think we need to revisit that, and that'll help with cost. But you're absolutely right. Australia still hasn't got public coverage for abiraterone, enzalutamide, or apalutamide for patients with metastatic hormone sensitive. So this is also a conversation that, to your point, Ted, needs to be region specific. So we can talk about the ideal scenario, but then as the slide I did mention that, can you access it in the patient preference conversation at the beginning?
That was great, Chris. And before someone else asks a question, I'll just say, you're always been an inspiration to me. You've just been really asked the right questions at the right time. So thank you for coming tonight.
Thanks, Ted. That means a lot. That means a lot. Not everyone agrees with you on that statement for that matter, but I'll take yours to the bank.
Just give me their names. I'll fight them for you, Chris.
I love it. Omar has done it for me already, so but I appreciate it.
Sorry, I am remembering the days when we met at the NCI. Remember to get the CHAARTED trial designed.
Oh yeah, for sure.
Yep.
Yeah, there was not a consensus around that by any stretch of the imagination.
Correct.
Actually, that's something for the trainees or the people who've still got energy, is if you've got a good idea, not everyone's going to believe it's a good idea, and you have to fact check it, you have to double check yourself and ask, if people are disagreeing with you, why are they disagreeing with you? And is it a legitimate reason? Take it on board. If it's not a legitimate reason, work around them. Because there was a lot of, every time you put a study together, there are competing interests in the trial design you're trying to put out there. What was good about metastatic hormone-sensitive prostate cancer in 2004 is there was very few people who were interested in it, other than Maha Hussain, maybe a couple of others. So it was an open field. Now it's a mosh pit of interest, which is good.
Chris, I have a kind of a nuanced question, but I just want to get your thoughts. And the answer is going to be, we need to do trials. But, I had some interest, and it may be just because of low data, but when the Pro-Repair B study was done, which was like it wasn't really a prospective study, but it was looking at, people going from hormone sensitive to castrate resistance and either choosing, an androgen signaling inhibitor or docetaxel and this was among BRCA2 mutated versus non-mutated. And they had a small population of BRCA2 mutated, but they found that those folks, if they were put on docetaxel, seemed to do worse than if they were going to Abi or Enza. And as we're moving PARP inhibitors up sooner in the spectrum, I wonder if you have any thoughts on the DDR mutated or particularly BRCA mutated population and how they may respond to docetaxel or not, or how you would sequence things as these other inhibitors. You showed some data with the PI3 kinase inhibitors come to light. And I know we need trials, but I'm just curious since we have you.
For sure. The data you point to, the first thing I would say is, my guess is the patients who were chosen for docetaxel probably had poor risk prognostic features, and someone said that we need to get doubling down. And the suspicion is they had more likely visceral disease or a poor response to their hormone. Would be my suspicion as to what the confounder is on that, without seeing all the data, obviously. But then I would also say we will hopefully be able to answer that question of the potential benefit of docetaxel, maybe less or more in patients who have DDR and hormone sensitive, with the data we're getting from Stampede and CHAARTED and ENZAMET in the exome profiling. So we will ask that question. So we don't need to do trials, we just need to analyze the data from the samples that we're sending to exome sequencing now. But I think the bottom line is, if a patient has progressed on their hormones, we profile them. If they've got a true DDR, and by that I mean BRCA1, BRCA2, not all the other sundry things that certain companies are pushing, I would definitely choose that over chemotherapy, because the return on investment is great. But even I've had a patient who responded really well to docetaxel with a DDR in their CRPC, and then they responded really well to the PARP inhibitor. So I do not think it means if they progress on the PARP inhibitor that they should not get chemotherapy if they're chemo fit. So I think it's weaving it in at some stage is probably the message I'm trying to say there, Ashley.
Well, that's wonderful. And then one more question that's maybe easier to answer, but just like Ted said, what I've been I've been impressed by many things from you, but one of the things I've been very impressed by is, yes, we're conducting these large randomized controlled trials, but there are biases on who's getting put on those trials and a lot of selection bias. And when the outcomes there it's sometimes not the best policy to look at the data in aggregate, but rather start to stratify it like you've been doing it, which is kind of, I don't want to put words into your mouth, but how do you teach, because we have a lot of the new kind of future residents on the call, how do you teach trial analysis and for people to sort of parse through the devil in the details type things? Is there any kind of mottos you use, or, you know?
The answer is controversial. Subgroup analyses, actually I would say subgroup analyses should have a big danger sign on them, but things that are dangerous can sometimes actually be helpful. It's just they need to be interpreted well. So yes, post hoc analyses, subgroup analyses without a clear prognostic variable, not accounted for up front, is very, very dangerous. But if you know a disease and you are interested in a certain patient population, then prospectively stratify it and try and ask that question in the trial design up front and look at the statistical design. So I know there's been a lot of concern with people across the Atlantic who say, oh, it's a subgroup analysis, we can't believe it. But when you look at all the rules, and they applied the rules for the radiation to the prostate, we applied the same to a prospectively stratified group, and based on the biology of it and the clinical behavior, knowing that the high volume do worse than the low volume. So handle it with care and ask, is it based on a clinical observation? Is it based on a biological observation? Does it make sense? Does it align with a certain factor? And then map it all out and then say, okay, that was an interesting observation in the first study. Now let's go and look at the next study and see, do we confirm that? And then what we're doing is trying to get this all into an individual patient data meta-analysis and say, okay, let's properly analyze this. So the test that a lot of people apply is the test for interaction, but it's really hard to actually meet a positive, be positive on a test for interaction. The treatment effects have to be really pronounced, that the point estimates are this wide and the confidence intervals overlap only a little bit, and that can be done. Now, you've got to have the whole patient spectrum within the analysis, or break it out based on your pre-planned specifications. So I can say with my heart on my hand on my heart, with ENZAMET and CHAARTED, we actually have prospectively stratified based on biology, based on clinical observations. And what I would say is, the more you see a disease, the more you get to understand it. And I had the benefit of working at the Indiana University, where I had the Ivory Tower University Clinic, older white affluent men, and the VA clinic, and I would have the same clinic on the same day, and there were two different versions of prostate cancer. And I went, there's two different diseases here. And that's why I've been focusing on the metachronous low volume as a distinct entity, because they clearly had a different issue. I don't know why Stampede only has very few of them. 40% of the patients in ENZAMET, 40% of the low volume patients in ENZAMET with metachronous low volume. So I think it depends on how frequently you use a hormonal therapy for a patient with a rising PSA as to how frequently you see a patient with metachronous low volume. And I suspect Northwestern, you, with a number of your legacy, you probably hold the hormones in a number of patients, I suspect. Don't treat everyone with a rising PSA with hormones, just select patients, I suspect.
That's exactly one. That was a phenomenal answer. Two is yes, indeed. And now that landscape obviously is in huge flux as PET imaging has changed it. So
yeah, and actually, I'm going to put 5 cents of your money that the EMBARK study with enzalutamide, Lupron, enzalutamide, or Lupron alone, whatever it is, will be positive in the biochemical relapse space for metastasis-free survival. The question would, let's be very clear, that's the primary endpoint, but that is not a surrogate for overall survival in that setting. So we have to show a clear clinical benefit if we're going to adopt these advanced hormones with all their costs and their side effects for patients with a good risk profile. But if you look at what we saw with the ENZAMET study, it's possible, because they've had the same median overall survival, that there may be a survival benefit. And that's really going to upset the apple cart a little bit.
Any other questions for Dr. Sweeney? Well, once again, that was really, I mean, thank you so much. It's really phenomenal. It's a great way for us to kind of have our Prostate Cancer Awareness Month and to have you as a speaker here. You know, if we can return the favor in any way, any of our faculty, I'm sure would be delighted. Have a great night. Thank you for everyone for coming. And we really appreciate you again, Dr. Sweeney. Thank you.
Thank you for the great honor and the lovely support. It means a lot.
Bye-bye, Chris.
Thank you.
We'll catch up on the other stuff. Bye-bye.
Bye-bye.